Thank you for the kind invitation, and congratulations for being very religious and being here at the end of the day. And thank you again for the kind invitation. So I was asked to give a primer for pediatric cardiologists. So I have some disclosures. I'm equally conflicted with everybody, and my whole life is off-label, so that's what I'm going to talk about. So pretty clear that no matter what your business is, that valve failure is bad. This is one of the valves that failed at 3 Mile Island. You don't have to be just a cardiologist to have bad valves. So why give a primer to pediatric cardiologists about TAVI? Is it natural for a pediatric cardiologist to do TAVI? Well, you guys are mostly used to this patient as opposed to this patient. But in fact, there's a lot of overlap, and a lot of the technical skills that you guys employ every day are certainly very applicable to TAVI. And I would argue that on a scale of 1 to 4, where a pulmonary valve is, let's say, a 3 out of 4, TAVI is really like a 1.5 out of 4. So, you know, if you put a sapien valve in the pulmonic position, I don't see what the big deal is, to be honest, about putting a sapien valve in the aortic position. I think it's more difficult. And if you put a self-expanding device in the pulmonary artery, I don't really, like a core valve, I don't really see what the big deal is putting in the aortic valve. I think it's a lot easier. The problem that I have is I don't like this whole concept of the half a doctor concept. So I think if you're going to do the technical part of the procedure, you really have to be involved in patient selection, understanding the disease prognosis, etc. So if we look at the skills required for TAVI, comprehensive geriatric assessment, one of my absolute favorite things to do. Comprehensive assessment of chronic disease, CHF, prognosis in adults with coronary disease and coexisting valve disease, cognitive assessment, a lot of imaging interpretation, coronaries, grafts, roots, peripheral vasculature, and angioplasty of coronaries if required, temporary pacemaker, large vessel vascular closure in diseased and calcified arteries, and valve delivery and placement. This is not, of course, to say that training cannot overcome and experience can overcome all of these different things. So the reason why I think it's kind of really important actually for pediatric cardiologists to know about this is because the way the equipment is evolving, I really don't think it's going to be too long before the pediatric population is actually going to see TAVI in their population. And I know, for example, in our institution, we have a number of congenital patients who've had bad Bentall operations who've gone on to TAVI. And TAVI really is, I think, the rock star technology of transcatheter valves. It's very difficult to argue that in terms of success. And there's a lot of very, very well-documented, excellent literature published in fantastic journals about, the success of these therapies. And, all of this really started in someone in Denmark's basement. This is the initial valve frame, which the patent came from Denmark. Someone, Henning Red Andersen, working in a very rough environment, put together this valve, 41 French sheath, the initial pictures of what happened. And just to tell you that not everyone knows what a winner is, because Circulation and Jack both turned down this initial paper in 1990. And finally, it was actually the Europeans who actually thought it merited a high enough priority to actually publish it. The last big randomized trial was the core valve high-risk study. 795 patients considered to be high risk, 3 roll-in patients per site, and then live for randomization. About almost 400 patients in each group. The mean STS score was 7.4%. This was a lower risk study than the partner study. It's very important to understand that. The STS score of the patients was lower at 7.4 versus 11.7 for partner. And the 30-day surgical mortality in the groups, were randomized to valve versus surgery, was quite a bit lower. That being said, this is really a home run. For the first time demonstrated that TAVI had an absolute reduction in mortality versus surgery in patients who were not super high risk. This is really outstanding. And also they had less numerical stroke. Not statistically significant, but less numerical stroke. That is as close to a home run as you can hit. So TAVI beats surgery with new operators. That's fantastic. So the question is, the critics would say, well, is this durable? Because durability is a major issue with TAVI. They're still asking that about percutaneous ASD closure. Well, earlier this year, the 5-year results of PARTNER was published, the high-risk study. So TAVI versus surgery, and there was no difference in mortality, no difference in stroke at 5 years. So very, very reassuring. And when you look at valve function, there's been no drop and no early valve failure and no increased gradients across the transcatheter valve. Very important data, especially if we want to proceed to lower risk patients. So really the question you should be asking yourself is, what's so great about surgery? Next slide. So I was going to put a slide of Kenny Rogers there, but I didn't have time to find it. So we pretty much answered the question of, does it work? And the question is, can we afford it, is a major thing. And, you know, really what we need to have in the TAVI world is ruthless pragmatism.
You did what needed to be done, and that's why I chose you, Jackie. Service background, clean history, photogenic, the whole package. But more importantly, ruthless pragmatism.
So if you're a House of Cards fan, you know that very well. What's ruthless pragmatism? Well, it means that with our present funding formula in Ontario, every hospital loses money with each TAVI, and many U.S. hospitals are in the same boat. And to do over 100 cases a year, you got to be lean and mean. You got to be awake and percutaneous and efficient and free of complications, and the patient's got to get out of the hospital. So the 3M trial is a trial that's just getting underway now that we're participating in. It's called the Multidisciplinary, Multimodality, and Minimalistic TAVI trial, and the aim of the trial is TAVI under conscious sedation, no Foley, no intubation, discharge home next day. 50 patients in, over 90% already discharged next day. Now, not everybody is good for next day discharge. This is something that I had Shaq Qureshi and John Cheatham work on for about 60 minutes. This is the clock they came up with. Usually to assess for dementia, we ask people to draw a clock with the numbers 10 to 10. Anyways, so if you have obviously cognitive dysfunction or something like this, it took them only 60 minutes. I gave them an extra 3 minutes, but anyways, okay. TAVI realities from a friend. So listen, you can get almost any patient through a TAVI. This is a patient with an EF of less than 20% with severe MR. They have 3, not 2, 3 occluded coronary arteries. If you can see, every artery is occluded. We did this patient awake on ECMO. We did him on ECMO because we knew that as soon as we paced to put in the valve, he would fibrillate, and he did exactly that. He was shocked. I had someone standing on the defibrillator. He was shocked immediately. 3 minutes after that, he was completely fine, ECMO out, home several days later, and he was done. This is my no snorkel picture to say that he wasn't intubated during the case. He was awake the whole time. If you do patients like that, you put your whole program in jeopardy, though, because what's going to happen is mortality is going to creep in. And so really, and occasionally, you will be the executioner in a case like this. And so really, sometimes you really have to take a step back and say, you know, maybe this person shouldn't be done, and really what we're trying to do is actually offer protection to the technology so that we don't just simply accumulate mortality, and we actually end up helping people get long-term outcomes. So what about valve choice? Well, really what we're looking for is no paravalvular leak, no stroke, no access problem, no coronary occlusion, no pacemaker, no death, and a happy doctor and patient. But really what we're looking for is 20-year freedom from all of these endpoints, and really we don't know that information yet. So what's an attempt to decide what valve to choose if you have multiple valves to choose from? Well, this is the CHOICE trial that got a lot of press last year at the ACC. 240 patients, randomized SAPIEN XT and core valve. The primary outcome was device success, which they defined as written on the slide with very experienced operators with both technologies. The only core lab in the study was angiographic, and remember, it's device success, so it's very acute. In this study, it appeared that the SAPIEN valve did much better than the core valve in terms of device success. Aortic insufficiency more than mild, more than one valve, so the balloon expandable did better. They found that at 30 days there was no difference in death, stroke, MI, bleeding, vascular complications, but in terms of rehospitalization, New York Heart Association improvement, quality of life, and new pacemaker, the balloon expandable did better. Also, in terms of AI at 30 days by echo, there seemed to be an improvement with the balloon expandable versus self-expanding, and this slide actually shows that there's more moderate aortic insufficiency at 30 days with self-expanding versus balloon expandable. This was confirmed in an MRI subgroup as well. This group, there were some downsides to the balloon expandable. There was more stroke, more coronary occlusion, and more annular rupture with balloon occlusion, with the balloon expandable valve. Now, that being said, they just published their one-year outcomes slightly earlier this year. There was, in fact, no difference at 12 months in terms of mortality. There was no change in AI that was noted. This was not a study powered for mortality. It was powered for an acute outcome. There seemed to be more stroke, not statistically significant, with the balloon expandable, and more CHF readmissions with the self-expanding. And as you can see at this little graph at the bottom here, when you look at total AI at 1 year, there was more AI here at the expense of none or trace AI with self-expanding. A very small study, 240 patients, but one of a very, very small number of randomized studies we're seeing. So when you have a lot of devices, how do you actually choose? Well, it's pretty difficult to choose. A lot of people in the literature are trying to make little small studies, 70, 100 patients that are consecutive, non-randomized, trying to decide, showing all kinds of difference. Very, very difficult to know for sure what's better. I think the only thing that you can definitely say is that if you get a valve, almost no matter what valve, you're going to do better than if you didn't get a valve. I think this will come out in the wash, and to be honest, it doesn't really matter with present generation technology what's better or what's not, because the devices evolve so quickly that problems are quickly fixed in a subsequent generation, and by the time you study the previous generation, the new generation's out and that problem is less important. Next generation from Edwards is called the Sapien 3. It has a sealing cuff. It has bigger cells to access the coronaries and smaller access size. This is an example of Sapien 3 that was done completely off-label with an annulus that was absolutely psychiatric in nature. And there is some aortic insufficiency that we were able to mostly get rid of. This is so outside the IFU, I hesitate to even show it. There's, I think, a very good result with a very, very difficult and large anatomy. This small study that was presented earlier this year showed in patients with 7.4% STS score that there was only 9% mortality at 12 months, which was really outstanding, and almost no stroke. This is the aortic insufficiency at 1 year. Only 2% had moderate AI. The only thing to highlight with this new technology from Edwards is the pacemaker rate is quite a bit higher than historical, likely related to the longer valve frame. I have 2 more slides. This is the new generation from CoreValve, the CoreValve Evolute arm. Mark Austin showed one of our cases from earlier. A completely retrievable technology, different stent design. So far, we've been extremely happy with it. Also, an inline sheath, very low profile. Definitely advantages, definitely something good. So TAVI for pediatric interventionalists. TAVI is an important therapeutic adjunct that needs to be tracked by the pediatric population, pediatric doctors, I should say, and the reason why is because it is coming soon to a hospital near you. Even though it may seem like it's way out there, it's going to be there soon. Technology and investment in these technologies will lead to continued improvement, miniaturization, and reduction of adverse events, and stay tuned. Again, it's coming to a hospital near you. Thank you very much.